majority of people are on. We have Abbey Such with us today for our July provider forum, and she is the OTRL manager at the Jacksonville Specialized Aging Program. And she's going to talk about how individuals with IDD and dementia intersect. So I'll turn it over to Abby, let her give a few little descriptions about herself and her program, and then she can go ahead into the presentation.
Sounds good. Thank you. So welcome everybody. Thank you so much for joining us today. My name is Abbey Such and I'm an occupational therapist and I work at the ARC Jacksonville. I joined the team here at the ARC Jacksonville last January. And I was hired to help develop this specialized aging support program, which we received through a grant from the Administration for Community Living. So everything with grants, we know that they come with some pre and post surveys that we turn in that we're able to keep our funding. So if you wouldn't mind, please just go ahead and scan this QR code and take this pre-survey. It's just a quick few questions. Your score doesn't matter at all. It's just to show the people that we've trained, hopefully gain something. You walk away from this training learning something. So I enjoy doing what I do here. I oversee our day program, but we have 3 different initiatives that we do with our specialized aging support program. So our first initiative, we call it our 3 pillars. So our first pillar is that we are trying to create a more dementia capable workforce. So you sitting here today during your lunchtime, listening to this training is one of the initiatives we do. We do this dementia IDD basics training. We have its behavior symptom management training. We train on a few different screening tools, and then we just try to promote the work that we're doing within the community. And then our second pillar, we provide services for individuals with IDD who are either at high risk for living with dementia. And I'll share what high risk looks like for us. And then lastly, we provide caregiver education programs. So every other month we host caregivers within our day center, and we invite experts from the community to come and talk about anything that's related to the aging process. So if you haven't already taken this survey, the link is inside the chat. So I'm going to keep moving on here. So again, we received just shy of $1 million from the Administration for Community Living to launch these 3 different initiatives with our specialized aging support program. So we're very grateful for their support and everything that we do. You know, our disclaimer always belongs to them. So I hope you guys walk away today with the understanding the difference between dementia and Alzheimer's. I hope that you're able to identify key characteristics of dementia in someone who does have an IDD, and then of course learn approaches for talking to someone with IDD and dementia. We touch on this just a little bit, but the behavior symptom management dives more into that. So if you're interested in that, feel free to send me an email after this and we can schedule more trainings with your particular agency. So a lot of times I give this presentation to people who are not involved in the IDD world. So of course, IDD stands for intellectual developmental difference or disability. So what is dementia? So a lot of times people who have intellectual or developmental differences are at a significantly higher risk of developing dementia. But let's go back to the basics of what dementia is. Now, dementia is the broad term of a group of symptoms affecting memory, thinking, and social abilities severely enough to interfere with your everyday life. So it doesn't cross that threshold. Yes, everybody who's aging tends to have a slight decline in memory, forgetfulness. However, it has to be severe enough that now your day-to-day life is impacted by it. So this is structural and chemical changes that are occurring within the brain. And I like to, this is from the Alzheimer's Association. This is a pretty widely used chart, but dementia is the umbrella term. So I always compare it when I'm describing it to cancer. There's so many different kinds of cancer. All of those people have cancer, but you might have, breast cancer or skin cancer. Dementia is our overarching term, and you may have Alzheimer's disease, which is the most common form of dementia. There's also vascular dementia, Lewy body, frontotemporal, among other dementias, and you could have a mix of several different ones. So this is actually what's happening to the brain when dementia is occurring. So it's truly shrinking in size. So when I'm training our direct support professionals, or I'm talking to different people about behaviors that are occurring, it's truly because the brain synapses are depleting. And so that means that what used to make sense to somebody in completing everyday tasks is truly fading away because the brain is physically deteriorating due to this disease. So these are typically, this is what the Alzheimer's Association puts out as 10 warning signs for the signs of dementia. So it's memory loss that disrupts daily life, challenges planning or solving problems, difficulty completing familiar tasks, confusion with time or place, and trouble understanding visual images and spatial relationships. The issue, I'll get to the next 5 warning signs in just a second, but the issue with this, when we look at all of these, is that people with IDD may have challenges in planning or solving problems at their baseline. So this is kind of hard to look at, difficulty completing familiar tasks. We might have some people with IDD who come to our programs that have difficulty completing familiar tasks that they generally complete every day. They may be confused sometimes with time or place. Maybe there's visual spatial difficulties in understanding that. So these are things that we could typically see before someone even shows signs of dementia with IDD. So that's where the general 10 warning signs becomes a little tricky when you're trying to diagnose someone who has an IDD. Again, new problems with words or speaking, that could be a sign that we look for in the IDD population. Misplacing things and losing the ability to retrace steps. I've worked with plenty of folks within our population that have difficulty retracing their steps and lose things all the time, but they're not showing signs of dementia. I've also worked with people with IDD who might have decreased or poor judgment. Maybe they're very passionate about what they want to be doing. Withdrawal is generally a good sign that we look for with people with IDD who might be showing signs of dementia, but you may have somebody who's always been withdrawn. And then changes in mood or personality, that is something that we see. So I show you all of these just to say that these are what the Alzheimer's Association typically shows. You know, if your spouse or your parent might be showing signs of Alzheimer's disease or another related dementia. However, this is not totally accurate when we're playing detective and seeing if this is coming about with someone with an IDD. I'm going to get into how we can look and see that though. So the normal signs of aging, like I said, it's an occasional bad decision. It's missing an appointment here or there. Maybe it's forgetfulness, but you remember later. You know, I can recall my grandparents forgetting where they placed their keys, but then an hour or so later they say, oh, I left them in the car. I left them in the door. Mixing up words on occasion, and then, you know, occasionally losing objects. So these are all signs of normal aging, which a lot, you know, every single one of us will show these normal signs of aging as we continue to progress throughout the lifespan. And this does not necessarily mean signs of dementia, because the key difference is that it interferes with everyday life. So occasional bad decisions is not interfering with everyday life. Occasionally missing appointments or occasionally forgetting things. So that is all just normal signs of aging. So we look at the different modifiable risk factors that come with Alzheimer's or other related dementias. And that's, you know, there's studies that show that poor diet and lack of exercise can lead to a higher risk of dementia. There are, you know, excessive alcohol use, cardiovascular disease, depression, diabetes, smoking, head trauma, and then vitamin and nutritional deficiency. So these are all things that we've seen. Research shows that if you can address these different things, your risk is, you decrease your risk of developing dementia, or you can delay the onset. But we know if these things are occurring, that we do have a higher risk of developing dementia. Now, there are some inevitable risk factors. Age, of course, as people progress throughout the lifespan, you are more likely to develop dementia. Family history has been shown to link to it, and Down syndrome is actually one of the #1 causes that, you know, is an inevitable risk factor. So the next slide shows Down syndrome is one of the most common risk factors of Alzheimer's disease, and it's the #1 leading cause of death in people with Down syndrome. And that is because the 21st chromosome carries a gene that contains a genetic risk factor for Alzheimer's. So this is why we are seeing it more and more within our population, because our folks are living longer and longer, which is wonderful. However, we haven't found a cure to Alzheimer's yet. So this is why it's becoming the #1 leading cause of death. I also like to point out that people with Down syndrome have a much earlier onset than the rest of the population, which I believe the next slide shows this in numbers. So most adults with IDD are at a slightly higher risk of an earlier onset, but Down syndrome is at a significantly higher risk. So this is the general population along this line right here. This is everyone else with intellectual disabilities. So you really see that spike, in the 60s to 70s, maybe 80s. But Down syndrome, you can see it as early as in, your 30s, your 40s, your 50s. And then by 65, the statistic is that about 95% of people have a higher risk with developing Alzheimer's who have a Down syndrome diagnosis. So it is significantly more prevalent with the Down syndrome population. So with that being said, we know that damage to the brain likely occurs up to 10 years prior to a diagnosis even occurring. So if we know that people who are, 40 years old may be developing it, our program here started addressing it at 30 years of age. So if we know that there is a chance that someone could develop Alzheimer's or another related dementia by age 40, we want to start taking those modifiable risk factors and changing what they're doing with their diet, with their exercise, with their nutritional intake starting at age 30. So when I say we have a high risk group, and then we call it showing signs or living with dementia group, we start our high risk group. Anyone with Down syndrome over the age of 30 can be considered high risk and can be admitted into our program. Everyone else with a different IDD diagnosis, we admit at age 50, which is because we generally see the onset occur with a non-Down syndrome diagnosis around age 60. So 10 years prior to that would be age 50. So that was our rationale when we received the grant of our inclusion criteria. So the typical approach to the dementia diagnosis is a detailed patient history, patients reporting what's going on, caregivers and families are reporting what's going on. We're describing how and when symptoms are appearing. We're diving into a family history. We look at their living environment and their emotional status. We do physical exams and lab tests. A lot of times we do these memory and language assessments that at a baseline level, our clients are probably not going to perform well, even at their prime. If they're in their 30s or 40s, they're probably not going to do these mathematical equations that we're now doing to detect if there's a dementia, if there are signs of dementia. So again, there's x-rays, there's MRI, CT scans to rule out anything else. However, this is the typical approach to dementia, and it does not necessarily work for our population. So I've had families come to me with full, neurological, packets that the neurologist has provided them after they've been through all of this different neurology testing. And it shows that our patients or our clients they're scoring at 0%. And I say this, don't take this to heart, because they're showing at a 0% compared to anyone else who's cognitively, their baseline was just at a different level than where our clients are being tested at. So that's not generally a great approach. So there's something called the MOCA. Normally, I meant to put it in this screen, but normally when I'm doing this training in person, I pass out the MOCA to everyone. So it shows different animals. So it shows like a rhino, it shows, I think, a lion. Anyways, it shows all these. I always say our guys would score perfectly probably on the animal section. However, sometimes you never know what the answer is going to be. When someone guesses what is a rhino, you might get a unicorn. When someone guesses a lion, they might say a tiger. So the animal, labeling the animals, I think our guys could do okay at. Then it says count backwards from 100 by 7s or 9s. And so after we get to 93, I have to start using my hands to count. So I think a lot of our folks might not do great on subtracting by 7s every single time. So there's just different cognitive tests. It asks you to remember certain words, and then 5 minutes later, we ask you what those words are. Different raising your hands when you hear certain letters of the alphabet. So it is cognitively challenging at a baseline to me for anybody, let alone for someone who has an intellectual or developmental disability. So all of that to say, the MOCA is not really an appropriate testing measure for our folks with IDD when we're trying to detect dementia. So we see that there's difficulty diagnosing the IDD population because of communication challenges. So maybe they're not able to express exactly what changes they're feeling. We do have one individual who attends our program who will say that the fog in my brain is just so strong today. And to me, he's someone who can articulate the challenges that he's having, but he can't describe exactly what that fog means to him. There's obviously pre-existing cognitive challenges, so it's hard to detect when we're using those different standardized tests. A lot of times we see fear of further labeling with families. So we see families who say they've been diagnosed with a disability for their entire life. We don't want another diagnosis. Like, we don't even want to talk about having this additional diagnosis for the rest of their life, because that means anxiety over the future. So maybe they're living independently and now they need to move into a community home. Maybe they are, doing pretty well, but now we're having anxiety over, are they going to have to retire from their job early? Are they going to be able to stay at their day program effectively? So there's definitely a lot of anxiety over the future, generally from the family aspect. Again, the inability to self-report, and then increased sensitivity to unfamiliar environments. That is because we all know, white coat syndrome is a thing. So when our folks go into the doctor's office or a hospital or this strange testing center, anxiety comes with that unfamiliar environment, which leads them to not performing well. And again, these tests that generally don't do well at detecting anything anyway. So there are different benefits to early detection. So we have an earlier onset. We said that we see it here at our program as early as age 40 of people who are we have a handful of people who are in their 40s who have a confirmed diagnosis. But the benefit of that is that we're able to provide them appropriate and targeted treatment. So no, we are not going to stop the progression. However, we're going to try to manage the symptoms while they're here. So we're still going to encourage them to exercise, because we know that there are so many benefits of them exercising. We're going to do cognitive stimulation to stimulate their brain, and engage in social activities and creative expression and nutrition. So we're maintaining their quality of life. There's also, we can hopefully delay the progression. That's what we're hoping to show through this grant over the next 10 years, is that we're able to delay the progression as it continues to go, especially for our high-risk group. We're hoping to see later and later diagnoses. And then it allows future planning for families. So what are next steps for the living situation, or for, what are they going to do meaningful during the day? So there are benefits of early detection. So the key difference between dementia and IDD is the loss of a person's typical level of functioning or baseline. So what do I mean by baseline? So this is what this is called. This is wording from a screening tool that we use called the NTG EDSD, and that stands for the early detection screening for dementia. So it says, has something always been the case? Has it always been the case, but it's getting worse? Is it a new symptom, or does it not apply? So this is a great example I love to use, because this guy loves loading the dishwasher. Every day he comes to the center, we know that him loading the dishwasher, it'll diffuse a behavior if he's having one. It gives him purpose, so he enjoys doing it. So he has always needed just a little bit of help. He's always just needed a little reminding that cups go on the top, dishes go in the bottom. So if all of a sudden it's always been the case that he needs a little bit of help loading the dishwasher. But if all of a sudden he's starting to put forks and spoons on the top and not inside the little basket in the bottom, that has always been the case, but it's getting worse, because now he's forgetting even just the general thing of silverware goes on the bottom. However, if he was totally independent loading the dishwasher and now he just needs a few subtle reminders, it would be a new symptom within the last year. And then if he's totally independent and loading the dishwasher, we'd mark does not apply. So the screening tool goes through these different areas of their life to assess, has it always been the case that they need help? Do they need more assistance now? Or is this totally new that they need new assistance? So another example, this guy attends our day program as well. He is a huge Georgia Bulldog fan, and I am a Tennessee fan. I have Tennessee stuff all around my office. And so he always makes fun of me because Tennessee has not been doing great. Georgia obviously has been doing well. So we're big SEC football fans. And so he always will kind of pick on me and say like, you're ugly orange, or, you know, you're Tennessee is going to lose this week. And so I know that he's always initiating conversation. Now, if all of a sudden he stops initiating conversation, I would find that to be a red flag. That would be something that I would mark on here that, okay, this is a new symptom because he's all of a sudden not reminding it. Now, if he did it here and there, you know, if I walked in with a Tennessee shirt on and he said, you know, oh, there's that orange again. So it could be that if he's prompted, he might be starting to initiate conversation. But those are things that I'm going to look at instead of saying, you know, start at 100 and subtract by nines, because that's not going to work for him. When we're deciding, is he showing signs of cognitive decline? So we're going to look at their social skills. We're also going to look at things, the big things that we generally see with someone who has an IDD is that, do they have an exaggeration of long-standing behavior? So somebody who has maybe always kind of not gotten along with somebody, are they having an exaggeration of that? Are they getting along with people less and less? We see significant weight loss or weight gain, generally on the side of weight loss, because people are forgetting those hunger cues. So we saw somebody who's in our program who lost about 80 pounds between February of last year and September. So in a very short amount of time, he lost 80 pounds because he lived independently. He was forgetting those hunger cues. And so we look at that. We also see weight gain on occasion because people are again forgetting that they've already eaten breakfast. So they eat breakfast again, and then they eat a snack, and their brain is forgetting to tell them that they're full. But again, especially with Down syndrome, we typically see a lot of weight loss. Changes in personality or friendliness are folks that are normally very outgoing, very vibrant, lively, always singing, generally tend to pull back and become a bit more reserved. Are they able to not keep focus on a task anymore? So they're changing in attentiveness. Onset of abnormal voluntary movement. So maybe they're just having different body movements that are unusual. We see increased accidents and falls because that visual perception is changing. And then we also have difficulty learning new tasks. So a lot of times, even coming into our day center, we opened in September, but we have people who forget, where is the bathroom? Where is the bathroom? And every single day we have to remind them, because it is learning a new task, learning the orientation of a new building since September. We see frequent choking incidents a lot because people, again, the brain is forgetting how to swallow correctly. So we see a lot of choking incidents start to occur. I always jump out of my chair and run into the program when I hear choking, because we know it's more prevalent within this population. Changes in hearing and vision. There's actually just a recent study that came out showing that if you address hearing loss earlier, you delay your onset of dementia, because the input of all the sensory that you're hearing, if you start to lose that, different parts of your brain start shutting down. So they're saying that addressing hearing earlier on can be a modifiable risk factor. And then late onset of seizures. So that is definitely, if there are seizures happening in the brain, there are obviously storms that are occurring. And so late onset of that, we want to address immediately. So that could be a sign. So this goes back to that screening tool. So these are all of the different things that we're addressing. So activities daily living. So again, we're going back to, has it always been the case that they needed help? Has it always been the case, but it's getting worse? Is it a new symptom in this last year, or does it not apply? So it's okay to mark does not apply. If they are, totally independent in going to the bathroom, they're not incontinent, it would be does not apply. However, if we're starting to undress inappropriately, it's always when somebody's taking a visit. I always say when there is a visitor, that's when somebody always decides to undress inappropriately. So if that's a new symptom, that's something we're looking at. Again, changes in communication. We're looking for those. Are they all of a sudden not initiating? Are they getting lost when we're trying to have a conversation with them? Something I always look at is how they're changing with their writing their name, because a lot of times they'll have bigger spaces in between each of their letters. So we try to track about every 6 months how someone's writing their name. So changes in memory, that's a big one. This is where it does kind of fall into the typical diagnostic process of people without an IDD receiving a dementia diagnosis, is because we're seeing those changes in memory. So someone who normally remembered the name of all of their familiar people, of all of their family and their friends, and all of a sudden they're forgetting those people. Are they losing objects? Are they forgetting track of time? We had somebody who was forgetting where they lived inside of our independent living community. So different changes in memories we're definitely going to see. There's changes in behavior. So are they wandering more? Are they withdrawn? Hoarding. A lot of times we see people hoarding tissues. A lot of times we see people hoarding pens. Say it again. Oh, okay. I thought there was a question. If there's a question, normally I'm used to doing this live. So if you do have questions, please just stop me and feel free to jump in. But we do see changes in behavior like wandering and hoarding objects. I wish I had this photo of somebody who was hoarding pens, and he was walking through, we're in Jacksonville, so we're with the Jaguars. We're big Jaguars fans around here. And one of our clients was walking through the metal detector with probably no short of 50 pens and some nail clippers in his pocket. And so we knew that he was hoarding objects, but his brother-in-law showed me this photo and the metal detector went off and they had to empty out all of these pockets. So I always mean to put that in there, but I forget about it until I get to this part in the training. But are they talking to themselves more? Do they not know what to do with familiar objects? So sometimes we'll hand people a brush and they'll just stare at it and they're forgetting what to do with it. Are they sleeping more, waking up more often? Are they wandering at night? A lot of times we might see somebody who's trying to leave the house in the middle of the night. Again, those changes in walking or ambulation, so we get nervous. We're definitely more aware of balance declines. Are they not confident when they're going over cracks? And then are they reporting problems? So yes, while this might be, they can't articulate exactly what's happening, they might be reporting that they're hearing things because they're more paranoid because of the changes that are happening in their brain. So that maybe they imagine a shadow as a person outside the door. Again, we talk about the guy that said, I just have fog in my brain, or my brain's just not turning on today. So they're having different changes that they're able to report on. So then we go into the different stages. I'm not going to dive totally into the different stages of dementia that we see, but the early ones, they're still generally able to keep up with their day-to-day within the early stage. So they might just start asking the same question repeatedly, telling the same story, trouble finding the right word, just minimal symptoms are occurring at this stage. Then we have still in the early stage, vocab becomes simpler and smaller. So we have somebody who used to rap a lot, and he still loves to rap, but all of a sudden his raps, they become a little bit more basic. So they're not quite as, the vocabulary is smaller in the raps that he now sings to us. So they have difficulty following direction. They might get confused or distracted. They're misplacing things, but really ADLs, they're able to maintain their ADLs. They're still able to carry a conversation. It's just that very beginning that something is changing in them, and I think we need to see it. Then we get to the middle stage, which is where we start forgetting more long-term memories. We have more confusion of where are we going? Why am I here? we have an increased need for level of assistance in personal care if they didn't already need that level of assistance. So somebody who's always needed assistance with personal care, with bathing and brushing their teeth, you know, that's not something that we're going to look at. But someone who used to be independent maybe needs a little more prompting, maybe needs a little more hand over hand intervention with them. Increased difficulty in recognizing people and remembering names. So all of a sudden, someone might remember your face, but tend to forget your name. So we see that a lot in the middle stage. We have disorientation of the schedule, poor judgment and poor safety awareness. So this is where elopement generally might start to happen. Mood and behavior fluctuate. So some days we're really happy, some days we're very sad. Physical changes are really starting to occur. So this is where we see more people having continence issues, forgetting even what to do in the bathroom. Sometimes we have folks who go into the bathroom and will, you know, dunk the toilet paper into the toilet, or just take the toilet paper off the roll and throw it in the trash can. So we're forgetting what to do. And those are, again, those physical changes are happening in the brain. Then the late stages where significant memory impairment is starting to occur. We're having difficulty recognizing people that we've known our whole lives. We become fully dependent for self-care activities, potentially lose the ability to walk, and then significant loss of speech and total incontinence in bowel and bladder. So this is where really we're, generally we would not see somebody attending the day program if they're in the very late stages of dementia. And then this is, you know, where I really dislike this part of the presentation, because there is no cure to Alzheimer's disease. And it is very challenging to watch our loved ones and the people that we've served for so many years now reach these points of decline. But there are new drugs that help slow the decline. There are different side effects that might come with these, but they do show that a lot of times I'll receive calls from group home managers and they say, you know, so-and-so's on this medication, I'm not seeing any improvement. And I say, well, we're not seeing improvement because there is no cure to it. However, we're not seeing a further decline. So are they potentially delaying the progression? Then that's good. But that's where we then get into the great part, which is where we are providing these different interventions that are happening. So what can you do for someone who has IDD and dementia? So I love meaningful activities, and I very intentionally choose these two photos to show, because there are different things that we do here at our day program. So we use, as an occupational therapist, I use so many different things, and I encourage our staff and our students and volunteers to use things that are not, you know, this is not what this ball was designed to do. This is an exercise ball that you can sit on, that you can, you know, exercise with. We use it for kickboxing, which is great because people can get out their aggression and they're punching it, because exercise is so beneficial for people who, for anyone in general, but also for people with IDD and then people who are showing signs of dementia, because it's stimulating your brain, it's getting your heart flow, your cardiovascular system pumping. Everything that we do with exercise is great. So we put on music, they do kickboxing. There's hula hoops in the back here that we don't use for general hula hooping. We use for stretching and moving our arms around, maybe for talk about social boundaries and walk around with them and not try to pop anyone else's bubbles. So there's different exercise things that we do. Then we, you know, meaningful engagement in participating with within the activities of every day. So if that's just putting a toaster in the, or a Pop-Tart within the toaster, that's great, because that's meaningful engagement. That's stimulating, that's validating for somebody. And I think our staff, specifically at this house that we're showing, I walked in there, the first day I walked in there, it wasn't a show or anything. Everybody walks in as soon as they get home from the day program, and they put all of their, they immediately empty their lunch boxes and they start making their lunch for the next day. So they pick out their snacks, they make their peanut butter and jelly if that's what they want. If they want to have pasta for the next day, they do that. So that is very important to keep doing as people have dementia, because meaningful engagement provides so much validation for somebody who is losing the ability to do everything else. So we also want to look at, if somebody is having a behavior, what is causing the behavior? So is it a health or medical condition? I always think of somebody, at the first place where I used to work, somebody came in one day and said their foot was really, they were having behavior. And I said, what's going on? And they said their foot was bothering them. And so I took off their shoe and looked, and their sock was just on funny. So it was bothering them because their sock was on all wonky and it was uncomfortable to walk. So that's not really a medical condition, but it's uncomfortable. We want to look at someone dehydrated and that's causing a behavior. Then we want to look at the environment. Is something super loud or overstimulating? Because the environment can be overwhelming to a lot of people who are having dementia. We also want to look at the task. Is it too difficult what we're asking them to do? For somebody who used to make their peanut butter and jelly every single day, can we, instead of telling them, all right, go ahead and make it, have at the kitchen, can we take out the supplies and then let them do it? Is it frustrating to maybe untie the bread and you can just untie the bread, but now they can do the rest of the task? So modifying the task to meet the need that they have. Unmet needs, is someone hungry or thirsty? Again, we say people with dementia tend to forget those hunger cues. So maybe they're hungry and they have no idea why, or they have no idea that they should even be eating. So look at their unmet needs. Also think about their life story. Has something happened to them, especially with like potentially trauma? Has trauma ever occurred within a bathroom? And now it's, you're asking somebody to go into the bathroom, but they're resistant to go into the bathroom because of abuse that potentially happened in the past. Are we asking them to go for a walk near a lake and maybe they had a near drowning incident? So look at somebody's life story and just remember what's going on. And then my favorite, could you be the problem? I am, always stay humble enough to realize that you could be agitating somebody. And sometimes you have to take a step back and think, did I do something to agitate this person? And a lot of times that can be something as simple as, I'm a pretty energetic person. I come in the morning and I greet everybody and I say hi, and I'm, very ready for the day when I come in. I've had my 2 cups of coffee and I'm ready. And I walked in the door one day and somebody was sitting there. And every day he'd just cover his head like this as soon as I walked by. And I thought, well, why is he doing that? That's weird. And so a student told me one day, like, Abby, he really likes if you come up and you talk in a quiet voice and you sit down with him instead of like your big bubbly personality. And so I was like, okay, I'm the issue here. My dad used to always tell me when I was younger, look in the mirror. And so I do look in the mirror and I realize that I can be the issue sometimes. So always see if you are causing the behavior, what can you do to work better with that client? Then what do you do? So this is where I really dive into, this is just a snippet of what our behavior symptom management looks like, but there's different things I always suggest people do when working with someone who has dementia. So the first thing you're going to do is try to redirect. Someone's having a behavior because they think there's someone standing outside the door and there's nobody outside the door. We're going to try to redirect them. Do you want to look out a different window? Do you want to go look at the birds? We have the fake purring cats that are very lifelike here. Do you want to go pet one of the cats? Do you want to go look at the bubbles? Anything to redirect them. So we're not even addressing the behavior that's occurring. We're not doing anything to talk about whatever's happening in their head. We're just trying to redirect them. If it doesn't work, we go to validation. So if they say there's a person outside the door, I'm going to just repeat back to them, there's a person outside the door. They're going to say, yes, there's a person outside the door. And so all of a sudden we're accepting their reality and they feel validated because we believe whatever they are saying. So accepting their reality is huge. If someone says there's a snake under my bed, I'm make sure there's not a snake under their bed, but then I'm going to again repeat back to them. You said there's a snake under your bed. Yes. Okay. I'm going to get a basket and I'm going to throw that snake outside. And generally they're much more calmed down when you accept whatever they're doing and you're diffusing the situation that's happening in their head. There's also, that goes along the lines of therapeutic fibbing. Now I look under someone's bed, there's no snake under there, but I'm going to believe them and therapeutically fib and say, you're right, I saw the snake, I got a bag, I took it outside. And so that is okay when we're talking about someone who has dementia because we're playing into their reality. And it all goes into our communication with them. So are we talking in a calm voice? Are we, being simple with our communication? Are we asking them to do 10 things at a time that aren't working? And that's not going to work because they need clear, simple, direct communication in a calm voice with somebody who's very understanding of what they're going through. And lastly, meaningful engagement. So if redirection doesn't work, if validation, isn't really working, if how we're communicating isn't it, can we get them involved with something that is meaningful? So could that be our friend that loves to unload the dishwasher? Hey, why don't we unload the dishwasher? Can you help me? There's so many dishes in the sink. Can you help me do that? Can you help me fold the laundry today? There's so many socks that need to find a pair. So finding something that's meaningful. It could also be something like, we have therapy dogs that come in here. So somebody petting a therapy dog. It could be watching a TV show, reading a book, looking at a photo album. All of these things are different meaningful engagements. A lot of times people will diffuse a behavior if you ask them to help with something when they have dementia. So a lot of times we try to get them to do something that's hands-on. So we can also modify the environment. So again, we look at noise. Is it too loud? I hear like trucks going by behind me right now. That can be overwhelming. Is the light, like the fluorescent light, really difficult for somebody or causing shadows that cause paranoia? Are there a large amount of people in the room? Do they know the space? We have a lot of signs around here that say, bathroom with an arrow. We have a lot of stop signs around our center to make sure that people are stopping before they elope. And can we customize the environment to do anything to individualize, to apply that individualization? So somebody that I was giving this presentation to was a nurse one time, and they said that someone had dementia and they were convinced that their wife or their husband was coming to visit at some point. However, we knew that the husband had passed away and that the husband was actually not coming. But because of getting to know this person, they worked at Dairy Queens. They owned a bunch of Dairy Queens. And so they told the person, oh, your husband is stuck fixing the ice cream machines, because apparently it takes a very long time to fix the ice cream machines when they get broken. And all of a sudden, we've now individualized the situation to whatever is important to that person. And she said, oh, well, if he's fixing the ice cream machines, I might as well just go to bed. So it's finding those different things, and distracting somebody to whatever is meaningful to them. So routines and consistency, again, as an OT, I'm a huge fan of visual schedules. We have established routines and consistencies within our day program. So they come in every single day. They have coffee immediately. They do their brain games in the morning. They move into exercise. They do a sensory, generally music or a life skill. Then they have their snack for our nutrition group. We move into our arts and crafts, creative expression activity, and they end the day with reminiscence. So every single day, we're doing new activities throughout that routine, but they're doing the same exact thing every single day they come in here. They know their routine of exactly how that day is going to play out, even if it's different activities. So think of things like folding laundry that can increase their self-esteem, and anything else that can, provide that consistency. Of course, if you're in the Jacksonville area, we'd love for you to refer to our program. So we have different activities going on here every single day. We have a great center. I love this wheel that we have. It's something that was maybe $50 on Amazon. Again, it's Prime Day. I'm not endorsing Amazon at all, but we use this wheel for exercise. We use it for reminiscence, and you can just do so much with color recognition, with talking about different categories of things. We love that wheel. And again, just emphasizing what our program does. I went over it at the beginning, but we thank you for being here because you are part of us creating a more dementia capable workforce in the state of Florida. We provide ongoing screenings like that screening tool. We look at people who are living alone and living with supports. We might do environmental assessments and modifications for people. I do an occupational therapy assessment on everyone that comes in, and then we always try to support our caregivers. So now we got to the end. You made it through. I think we did good on time here. So if you'll take this post survey, that would be great. We have, we again, can submit your name if you've taken the pre and the post test, and we can submit your name to be entered for a drawing for a gift card, and we'll send that to you via email. Yeah.
Great, well, thanks so much. We're gonna open it up for any questions. You can unmute yourself. I will just reiterate that we will send a copy of the presentation to all those that attended, and we will also place this meeting on our YouTube channel by the end of the week. So does anyone have questions or comments for Abby? I don't see any questions in the chat just yet, so if you do, you can go ahead and feel free to unmute yourself if you have to ask a question.
Oh, yes, I'll share my email.
We will put that also when we send the presentation. We'll include Abby's information, but she also put it in the chat as well, so.
Yes, and I will put the survey link in the chat as well for the post survey. Thank you.
So very informative and informational.
Yes, I'm really happy to see you guys. We'll take this back to your staff because I think we're only going to continue to see more and more people who have dementia within our population. And we have to be able to adjust as they're aging throughout this process. So there are different things. I also have a training on environmental modifications. So for looking for tripping hazards within the environment, things as easy. There are simple fixes that we can do. I just went into one of our group home. Oh, thank you, Rachel. I'm glad you're a Vols fan. I'm just seeing all these come in, but things as simple as painting a wall, a white wall with a white toilet with a pretty pale floor. We just painted the wall blue. So now the toilet stands out more. So now we're going to have more success of people being independent in the bathroom. So that's just like a simple environmental modification, but I have lots of recommendations for those environmental modifications that we can also provide training on.
Well, great. Again, we appreciate it so much. And we will send this out. So we thank everyone for joining.